Who'd like to start?
Yes, sir.
I was just wondering, how would you accommodate tertiary care?
In relation to our hospital.
How we go about the process, is that really what you are asking? Because what we do is we work with the medical staff. I mean, you guys treat the patients. You know, and I mean, we can give you the demographic data to tell you what's going on. So we're looking at solid statistics. But you treat the patients, and you live in the community, and you know what's going on, and you know what's necessary in the community. What we want to do is gather that expertise and develop a strategic plan for the hospital, which includes the components that we've discussed earlier, between the recruiting, the investment, how are we going to lay out the investment, and what services do we need to bring first? Josh talked about the fact that we have toolkits available. Let's say cardiology is an area that you guys really want to grow business. You want to talk about that?
Well, I'm not sure I understood the absolute question, but it's like, are you talking about tertiary services that are not provided in the hospital?
Yes, sir.
I think it's important. I think it's a two-pronged approach. It's a hospital approach. It's a medical staff approach. The relationships, we have pretty good relationships with the tertiary facilities surrounding our hospitals and all of our communities. And two things. One is physicians do the referrals. I mean, they're the ones that have a preference, really, of which maybe heart surgeon they may use or specialist they may use. But we definitely have a relationship with the tertiary referral centers. We have transfer agreements. And quite frankly, I personally, or the hospital CEOs meet personally with the leadership of those tertiary facilities, say, okay, what do we need to do to make sure we slick this out so there's not a delay in care for the patient? And we have good experience in that. Because when you're a community hospital, I think I said earlier, we can't be everything to everyone, but we need to make sure that we can provide everything to everyone, and that may be in the form of transfer agreement. And we have good relationships with our Haines City Hospital in Davenport, with some Orlando hospitals. I mean, when you look at the map, we have hospitals in Haines City, St. Cloud, Bartow, Sebring, all the areas in Central Florida, and we really don't have any issues in transferring patients, especially for that tertiary care. I'm very confident we can establish those relationships. Could we do it?
Okay.
I understand one of the major changes around here is you're going to input your IT system into it because you're the low cost of that. What other changes would we experience here as far as strategically with management and with employees?
Well, typically, initially, there's very little change from the standpoint that what we need is local management. I know there's some plans here for, Richard has some plans for his future. He told us the other day, but But at any rate, we want to work with the community to develop a clear plan and direction for how we want to develop the hospital to march it forward into the future. And so initially, it's about putting our processes in. We talked a lot about the ER. We have an ER process. It's not to say that you don't have a good one. Okay, that's not. It's not about saying that what you have doesn't work, but it's about saying that we have a process that we know will shorten those lengths of stay, which will be beneficial to the community. I don't know whether you guys want to add.
Yeah, just adding on, I think you asked about the employees and the leadership here. First of all, for the employees, every employee that on acquisition minus day one to acquisition day one, they all come over. They come over with their seniority and their tenure. I have to be honest with you, I haven't seen your benefits. Our benefits are very comparable, sometimes better, many times better, to be honest with you. So all the employees come over in that. The local management team stays. I will tell you, again, I don't know what the plans are. CEO and CFO, those are usually people we talk to make sure what their plans are, but the rest of the management team stays. No guarantees. I don't know the strengths and weaknesses of your management team, but it's a locally driven process. We'll talk to physicians, say, hey, what do you think's going on here? Not to say that the physicians are going to decide that, but we do get input from the local hospital teams, but everyone comes over on day one. And we work together and see who can work with our strengths, who can work with our weaknesses. And I think we're real good at developing our management team. This is not a matter of, you're no good, you're good. That's not saying is we develop our managers. It's a failure on our part if we can't be successful with the teams we have in place. We don't manage from Naples. I mean, you know, you just don't. It's a locally driven issue.
Yeah, just briefly, I try not to say too much. I usually get in trouble when I say a lot. They keep me in the background.
We're recording it.
Okay, I know.
Please send me a copy.
That's why I've stayed in the background till now. But it's interesting why we're successful is when we partner with communities. We really truly believe it's a partnership, even if there's no financial relationship. Is because you can't cookie cutter healthcare. We can't do that from Naples or anywhere else. Every market's unique. Every market, the dynamics change at different paces. The medical staff has different expectations and needs, and the community has different expectations and needs. As we get involved, as Josh mentioned earlier, you know, he talked about strategic planning with the local board and the medical staff. That is truly the method we use to determine where the facility goes, what services are offered, which ones we enhance, what new ones do we bring, what type of medical staff specialty are we going to grow. In other words, we take basically a whiteboard and we start drawing and listening to what the medical staff and the community says they expect their facility to be. Because at the end of the day, we could come in and say, well, we're going to do this or that, and if it's not wanted or expected or it can't be supported in the community, it will fail. And we don't want to fail, and we don't want to fail you. And from that standpoint, we have to listen. You can't cookie cutter healthcare. I can't overemphasize that. It's very local, and the dynamics change at different paces.
Maybe on that same note,
not sure what I heard you all say community hospital a lot. I'm not exactly sure what that means, although we like the word community, and that's what we consider ourselves here. But I think we also have a vision for being able to provide those services and maybe want to do it in a quick fashion such that, or at least my thought is, such that all the services are provided here. You propose some structure there. Is there some maybe adjustment to that structure that could bring those services to us quicker so that we know we can't get 100% of those services here quick, but if we can get 90% of them, it'd be, I think, a mission of a lot of us. So,
you know, if I can, the issue of providing services or a new service, let me tell you, the easy part's equipment. We got the capital to do that. That's the thing. The second easy or the harder part is making sure we have the staff to do it, the hospital staff, the expertise to do it. One of the great things about having 23 hospitals in Florida is we got staff that can come in and help train and start programs. Probably the hardest part is making sure we got the doctors to do it, the specialists to do it. That's the thing that would probably take longer. Now, if we have, what I like to do is work with doctors in the community, and I don't know, say you want to start a, this is just an example, but just say you want to start an open heart program or an interventional cath program. My goal is there's doctors in the community that for some reason may or may not use this hospital because you don't provide the service. Doc, here's what we want to do. How can we make it work with you? Because, you know, bringing a new doctor in the community and we're going to start a new program, you still got to have referrals. It takes time. You want it quick. You got to have the physicians involved making it work. I can get you the equipment. I can get you the people. We got to make sure we have the medical staff to do it. And I think that's the key. And the key is working with the medical staff we got. And there's always, you know, there's always physicians out there looking to expand their practices, quite frankly. And if it's specialists, trust me, they're under the same economic pressures everyone else is, and they're wanting to do more. And we work with the local physicians. And then you'd recruit, but that's how you do it. And it can be done quickly. We do it. I do it. I'm the operator guy. I get excited. So we can do this stuff.
You know, one of the things I should mention is, you know, we do have a tremendous amount of resource available that a community hospital typically has to acquire on its own. You know, physician recruitment resources. We have, for example, teams of physician recruiters internally, and we source physicians. We have great tools from an electronic standpoint where physicians can access opportunities for the company, and then we have people that manage that on a daily basis and process that. We have legal resources. We have construction management and design resources. We have everything. So our ability to move swiftly is enhanced because a lot of those resources are internal to us, and we don't have to buy them. And it's not different from this project to that project. And we have seen some synergies from the fact that we've developed, for example, an open heart surgery program in the hospital. Why? And why can't we take some of those same parameters and apply them in terms of how to develop, how to get the staff trained, how to, the best equipment to use, which we consult with the physicians, and all those things. It's pretty dynamic from the standpoint. The resources that we have are just tremendous. I could list them, and it'd take most of the rest of our time to do that, so I won't do that. But we have a lot of those resources. We can move on a pace that maybe historically haven't seen, and that's not a critical just because we do this all the time. For example, we've presented to community boards and community leaders and hospital executives and physicians many times about our company. Probably this will be the first time and maybe the last time for many of you. So from that standpoint, you have a lot of questions about what can a company like Health Management do, and how can they partner with us. And I think this should be just the beginning dialogue about that type, because there's a lot of resources that we have that we certainly like to share with you as we go forward.
I don't think we can overemphasize your question, and so I'm going to add a little bit to it. It's developing a strategic plan, and I'm sure that Richard and the board here, that you guys have developed a strategic plan, but maybe parts of that strategic plan you didn't develop because you didn't have the capital at this time to do that, or you put it on a longer time frame than you would if you were reevaluating in a different resource environment. So that's what we would want to do, because you guys know your market, you know where you're at. Okay, we need to find that out by interfacing with the people that live in the community.
I have a question. You referred a couple of times, and it was in the slides, to Physician Leadership Council.
Yeah.
As that being different than
Yeah.
MedExact.
Yeah, yeah.